So it's not all of our SAB, but a significant part of our SAB are here. We've got more chairs, and it's like English buses. Excellent. Does anybody want to join the SAB while we're here? You can have a chair. Excellent. Fantastic. So what would be great is just quickly, if you could say very briefly who you are, where you work, and one line of what your expertise is, starting with Paul.
So I'm Paul Northcott.
You can use the microphone.
Yes. Paul Northcott. I was at this event last year, and they didn't invite me back to speak. So I don't know if it's a bad sign or not, but so I work at St. Jude Children's Research Hospital, which Richard mentioned earlier. That's where he spent 15 years, and now I've spent 4 years. And I work on the pediatric brain tumor medulloblastoma, trying to understand its biological basis at a very grassroots level so that we can find better therapies and cure those patients of that deadly childhood brain cancer.
Thank you, Paul. Like all Americans, he doesn't understand English. So, thanks, Paul.
That was more or less one sentence.
Yeah, it was an American sentence, sort of run-on sentence. We've met Susan, we've met Colin, Steve.
Hi everyone, I'm Steve Clifford. So I run the Childhood Brain Tumour Programme up at Newcastle University. Like Paul, I work on a disease called medulloblastoma, and in particular, my work's based around trying to find out genetics and biology of the tumour, which we can use to deliver the best individualised treatment to every single patient. And right now, we're rolling that out to all patients across the UK.
Thank you, Steve. Ken?
I'm Ken Oldape. I work at the National Institutes of Health in the US, and I'm a pathologist, and I work in the genomics of brain cancers, including glioblastoma and meningia.
Brilliant, thank you. So we've got some of the true world's experts here. So really, this is your part of the evening. So what I'd like to do, if you've got a question, the only stupid question is the one that's not asked. So raise your hands if you've got a question. I'm also going to do something slightly different this year, is that while we've got all these fantastic patients, survivors, caregivers, it's an opportunity for us as scientists and doctors to ask you questions as well. So we will do that as well. So any questions? Yes? If you could say what your name is, where you're from, and then your question.
Firstly, let me say I'm slightly scared and intimidated. I'm a speech and language therapist working in neuro-oncology. So I'm very much coming from the quality of life point of view. I work out of the Royal Surrey in Guildford. I haven't been doing the role very long. I'm a neuro specialist speech and language therapist by training. I just wondered where you see AHPs fitting into the whole brain matrix mission. Sorry, allied health professionals, so things like physiotherapists, occupational therapists, speech and language therapists. I'm truly blessed where I work in that we're allowed to have specialist speech and language therapists, physios and OTs, specifically working with our neuro-oncology caseload. But what I see is that isn't translated in many areas at all. And I just obviously think it's a hugely important role, and I just wondered where that was being considered and where that fits into the Tessagel issue.
Thank you. I'm going to ask maybe Colin to start with that question. So what's the role of allied healthcare professionals?
So on the way down on the train today, I was writing a document about how we can get allied health professionals integrated into the Brain Matrix program, part of developing a strategy for patient-reported outcomes. It's not just about speech and language, it's about occupational therapists, it's about physiotherapists, it's about clinical neuropsychologists and neurophysiologists. It's also not about just what goes on in the operating room. It's all very well and exciting and melodramatic, but a lot more can be done, both pre-operatively and post-operatively. And I think going forward, the strategy is to engage with allied health professionals throughout the whole course of the journey. I think in the UK you allude to the fact that this is not particularly widespread, and you're absolutely right. And I think the investment in allied health professionals has been inadequate. I think because you're dealing with a relatively uncommon cancer, and you're dealing with patients who are not in a position to aggressively advocate for themselves, you have additional challenges. But one of the things about sharing a platform with Susan Chang is you can then say, okay, this is what we want to do. These guys did this about 5 years ago. So if I hand over to Susan, she'll be able to sort of bring you up to speed with what it looks like so we can jump forward in time.
Yeah, I mean, I think that's really critical that we try to have an assessment of each individual patient. And I think, you talk about precision medicine, we sort of think of it as the therapy side in terms of making sure we get the right treatment at the right time for the right patient. But it's also about, taking care of the patient and the family with information and resources at the right time and the right place. So, for example, a very simple thing, and I think I actually learned this from one of the groups I work with here, where we now have someone who meets with the family after the patient has an operation. So a lot of times that patient's recovering, they're in the ICU. We actually now have someone where they get a big binder of all the things to expect, because as you all know, a lot of times this is a very sudden event. You're going along your life and then something heralds a scan that needs to get done, and then next thing you know you have an operation, and the family has to be the doctor, the nurse, the physical therapist, the pharmacist, the social worker, because they have to deal with, well, at least in the United States, all the insurance issues as well. And so we really felt that there was such a big degree of stress at that point that we needed someone to come in and sort of make sure that they could navigate what to expect next. And then at different time points, we check in with patients and families and so forth. But I think that's the kind of sort of looking at the whole trajectory of the illness and trying to recognize what people need at each point.
Great, thank you. And in terms of the mission, so I mentioned the patient-facing aspect that Sarah's leading from here, along with Jess Mills, and that's placing those multidisciplinary teams in terms of Tessagel branded centres. Initially that's around a nurse, neuro-oncologist, radiation oncologist, imager and neurosurgeon, but obviously once that's founded there'll be the additional team members that will add on to that. So did that answer your question?
Yes, it did.
Great.
I just think I absolutely agree that I actually work in the second stage.
I don't work at the time of surgery, I work at the time of the radiotherapy and chemotherapy, and we're developing a really improved pathway to, so simple things like having a speech therapist or an OT, just observing in that initial consultation, so that actually we can see whether that patient's even understanding what they're being told. Because there's no flag up of communication difficulties or cognitive difficulties prior to that consultation. So I've been in a consultation where I've had the family in tears sat behind the patient, and the patient's still smiling because they haven't understood what was being told. And on that basis, they're meant to be consenting to treatment. It's a little bit scary.
Great question. There's a question at the back, I think. Is it Martin?
Yeah, Martino.
Martino.
I am very similar to that character that you were just describing, as in I am 8 years into glioblastoma myself, but my family was aware of what
That's
I had.
fantastic, yeah.
I was one person there while everybody got this information about what I had, and my sister, my mom, everybody understood it. I didn't. It was exactly that. I lived in this strange head while everybody around me was very scared by the statistics of it. And it was strange, but at least I lived quite happy in a weird way. But the question I find it fantastic, the fact of seeing this in a different way of other problems, so my mom, my whole family, is a very important thing. But my question to it, since I'm a freak, I always need to try different things. I'm doing keto dieting right now, which is extreme and difficult to live with it. But I need to be active to do it, which is healthy. And my relationship then with the family by feeding me this weird food stuff makes, once again, healthy, you think? Is it possible to have a discussion about how these things are truly healthy? As in, because it's like, oh, do whatever you want, is what I get from oncology normally, because they don't care. Well, I find if my mom is calm, because she's got to do something, makes me calm, and somehow I feel that that's truly why I'm still alive. It's because of having all the calmness, and we managed to do something that obviously was just me living in all the time, you know. So
So the question, Martino, is
can we actually talk about that as actually healthy? As in, do I feel better because of these weird things that I do, or because of doing stuff with my whole family together to do a project? Is that healthy, or just something to do for the hell of it?
That's a typical question. I mean, I can give my response, and it'd be great to hear from the panel. But what I would say is, it's fantastic that you're well, right? And you're an 8-year survivor, which is absolutely fabulous. So congratulations to that, Martino. From my perspective, I don't see patients anymore because I'm sort of involved in research and administration. But my relationship with family is that they needed to find what was right for their family. And we don't understand everything as doctors. We don't understand everything as scientists. And if it helps a family manage a disease, whether it's a keto diet or whatever it might be, you should support them in that, in the decision that they make. Because as you said, it brings calmness sometimes to a family that's otherwise in deep distress. And the medical profession does not help by poo-pooing or dismissing something that a family is engaged with. And actually, there are other benefits of that. We know that. So if you're committed and engaged in some aspect of parallel medicine, as long as it doesn't distract you from being involved in other aspects which we know will bring benefit, it often makes you better and more objective and actually more engaged in those other aspects of medicine, particularly if medical professionals are willing to engage in that with you, because otherwise you just set up conflict with the family. But it'd be good to hear what the rest of the panel think.
So I'm just a surgeon, but from my perspective, one of the things that we see, because we see patients at the beginning of their journey really, is this complete sense of loss of control. You've got you can't do anything, and everything is happening either too quickly or too slowly, and it's all out of control, and it's all very frightening, and it's all very confusing. I personally have found two things that really seem to help patients. One is having something about their care and life that they can take control over. I find that patients seem to really relate to that, it really helps them. The second thing is maintaining a positive attitude. And I have seen patients decline very, very quickly, who I don't really understand why, because part of it seems to be that they've given up. And I think if the fact that you can control your diet, or you can control some aspect of your life, if that in turn helps you have a positive attitude to your disease, so it becomes something that you're going to fight with, or something that you're going to live with, rather than something that you're going to give into, then I think those two combined are absolutely critical.
Susan.
So we actually have the opportunity to have every patient have a nutrition consult in our group. This is through the Cancer Center. It's a phone consult, and we just make a referral, and they contact the patient and talk about ways that they can improve on their diet. We also have a wonderful integrative medicine physician and a team. So thinking about how to take advantage of alternative or complementary types of approaches, whether it's diet, acupuncture, and things. We also do have that kind of opportunities for patients and families as well. So I think you're right that it's really listening to the patient and the family about where they feel that there are areas that they can help control, but also try to have a positive, as Colin was saying. So I think that there are ways to address those types of issues as well. The other thing that I'm actually starting is an exercise physiologist to see all of my patients being radiated. Because radiation is 6 weeks long. You're a captured audience kind of thing when you have to go every day for radiation. And so we're now going to have an exercise physiologist assess every patient who's being radiated so that they can get into a program to understand about their balance, about whether they have weakness, and sort of help them get into a program because it's been shown scientifically that if you exercise, you actually sleep better, you tolerate treatment better, and so forth. So we're trying to institute that as a standard of care for every patient undergoing treatment at our institution as well.
Great, thank you, Susan. Next question. Yes, 2 questions on the front here, and then there's a bunch. That's great. Oh, yes.
So we've got a question here about inoperable brain tumours. Are there any advances on the horizon and any UK-based clinical trials coming up?
There are certainly advances in surgical technology, and if I look back over the past 10 or 15 years, when I started as a consultant, we would do a craniotomy, a big operation, on about 20% of patients, and we would do a biopsy, just stick a needle into about 80%. When we started developing the specialist programs, and we re-audited that 5 years later, we'd reversed it. We were biopsying 20%, and we were operating on, doing craniotomies on 80%. Our morbidity was down, not up, and the outcomes were better. That involved applying the basic surgical techniques that we had then, and that cannot be underestimated in its importance, getting the basics right, and that still is not happening everywhere. So I think a critical factor that the Brain Cancer Mission is doing is developing this specialist care pathway, which is what we set up in Cambridge, and we published on it back in 2011. It's sometimes referred to as a Cambridge model. I think that's critical. If we move forward now, the next trial that we are hoping to get funded, which will be run out of Oxford, is bringing together intraoperative imaging using ultrasound together with MRI scans to look at the fibre connecting pathways that we were talking about earlier. Combining that with intraoperative monitoring techniques and intraoperative fluorescence guided surgical techniques that are essentially designed to help us to operate maximally but safely. I think it's important to remember that if we do a good operation but a patient has a new neurological deficit, we've not done anybody any favours. In terms of new trials then, that is what's coming. We hope that will be funded through the NIHR. In terms of additional studies, I think Dr. Chang alluded to imaging. I think that is also critical, not only to inform how we do a surgical procedure, but also perhaps more importantly to help us understand when treatments start to fail quickly, as soon as possible. The role of surgery in the context of progressive disease is an area that we still do not have any sure. But one of the big challenges that we have with respect to the scientists, and I would love to get your opinion from the audience, is we have very little opportunity to collect tissue during the course of the disease. A lot of patients with a brain tumour, particularly the more aggressive ones, in the UK at least, they will undergo treatment, and then when the disease progresses, they have basically best guess treatment. They don't get any further tissue taken, we don't take any further samples, and it means that the scientists, like some of these guys around me, don't really have any information as to what's actually happening. Now, the Brain Tumour Charity did a survey a while back, and maybe David and his team comment, but apparently, I think if memory serves me, about 73% of patients said they would undergo a biopsy even if it meant nothing particular for them, but it helped to understand the disease. Now that as a conceptual challenge would be a real groundbreaker, but of course surgery is not without risk. So is that something we should be thinking about going forward?
So thank you. Just to quickly answer that as well, I mean, I don't know where the question came from, but our job is to put Colin out of a job so that patients don't need surgery, and Colin would be delighted if we put him out of a job. And so there are efforts, so for example in paediatrics, that myself, Steve and that Paul are working on to develop treatments that actually are completely different from radiotherapy or cytotoxic chemotherapy. So for example, we know that a lot of the tumours that occur in children represent tissue actually quite very similar to what exists in an embryo, right? But now it's existing in a 5-year-old child's head, and that tissue doesn't normally exist in that child. So what's exciting about that is almost anything on that tissue could be targeted with a new drug. Because if that tissue only existed sort of 5 years previously and is no longer existing in the head, then it could be a non-toxic treatment, and that's what we're working on, and that would get rid of the need for surgery. Next question. Just remember your name, what you've...
Oh, yes, right. My name's Julia Cruz. My eldest son died of a brain tumour not quite 2 years ago. He actually was a chemist and a lawyer and very, very committed to research. So he signed up for a trial, but actually was too poorly then to go on it. But what he did do was he signed that his brain would be donated to research. And I think one of the most important things that maybe, you know, as a family, my other two sons are with me tonight, as a family we have taken tremendous reassurance from and comfort in a very strange way, is that Matt's brain is now with the Epilepsy Society. He suffered from epilepsy subsequent to the tumour, and that will be used for research all over the world. And what I would like to see encouraged, if possible, is somehow, it's a heck of a difficult decision for a lot of people to make. Fortunately, he was able to make it himself, but for people to donate tissue.
Well, first of all, thank you very much for that, because that's incredibly helpful to us. I know in paediatrics, actually, that's become quite routine, actually, and you're right, it's a difficult decision for families to make, but at the same time, out of what's a terrible situation, can provide the kind of hope that you're talking about. And one of the brain tumours that we look after is called a DIPG, diffuse pontine glioma, and that's essentially incurable, and it's not usually operated on because it's in a part of the brain which is so sensitive. And remarkably, families have actually consented to post-mortem donation of that tissue, and actually because of that, over the last 10 to 15 years, it's completely changed our understanding of that disease. 15 years ago, we were completely in the dark about that disease, and some of the most interesting observations in mutations, changes in genes in cancer have been made just by studying those diseases that those families donated. So thank you for that, and that's actually critical for what we do.
Hi, Greg Girard, glioblastoma multiforme 4 and 2.5 years. So the question, and I haven't had sugar or starch for 2.5 years either, but I won't go into that. Anyway, the question I have is there work going on the predictability of drug effectiveness on each individual person? Because there's a lot of people out there that the drugs are completely useless, but the patients struggle through taking these things only to find out afterward that they were useless. Is anybody trying to look at perhaps the genetic level to be able to predict that sort of stuff so that people who aren't going to get helped by the drugs don't have to take them?
It's a great question. So maybe I can kick off and then I'll probably bring Paul in because you've not answered a question yet, Paul. So you need to get, for your vast salary, you need to be able to answer questions. So one thing is that we're a little bit stuck between the mechanism of clinical trials. As you know, we do clinical trials because we need to see statistically, numerically, a difference between one treatment and another treatment, and that takes a number of patients. Now, 20 years ago, 30 years ago, when I first started practicing, it was exactly as you said. Everybody got the same treatment, regardless of what they had, and we would just fire a treatment at them. What we've got better at, particularly in pediatrics, where we work, is understanding that one brain tumour, whether it's a medulloblastoma or a ependymoma, is made up of 4 or 5 very, very different subtypes of disease. We've already proven in medulloblastoma, for example, as one group that's curable even if you almost just do nothing, just give a moderate amount of radiotherapy, chemotherapy. There's another group, group 3, that Steve works on, for example, that actually is almost incurable. And yet those patients were getting the same treatment. So we've actually taken steps to give different treatments depending on those genetic subtypes. The glioblastoma is more difficult because although it is a heterogeneous disease, we don't have those robust subtypes yet to say this patient will respond to X, Y, and Z. What we tend to do is do mutational analysis, look for mistakes in genes that could be drug targets. But even then, it doesn't predict necessarily that you're going to respond. In fact, it usually doesn't. So that is why looking for new roads in new therapeutics is a way forward. But Paul, I don't know if you want to comment on that.
I'd absolutely love to comment on that, Richard, especially after you answered the question for me. But I'll do my best to follow up and build on that. So a lot of the work that we do, and Steve and Richard as well, and likewise Ken, is to collect tissues for all the different brain tumor types that we study and understand their genetics. And so we use the most cutting-edge technologies that are available now to really basically understand every gene and every sort of group or subgroup, as Richard was alluding to. And now by linking that information with patient outcomes, usually in the context of clinical trials, we can identify patients that will do well when they're treated with standard of care. We identify patients that do poorly when they're treated with standard of care. So in that realm and in that arena, we've made a lot of improvements over the last decade. I think where we're struggling at the moment is how are patients going to respond to new therapies? And this is what we're all excited about, is to identify sort of new targeted agents and so-called precision medicines that are going to basically take the place of radiation therapy or take the place of cytotoxic chemotherapies that don't work in the first place. And the problem is we don't have models that basically recapitulate or represent all of the different genetic variants that we see across glioblastoma or across pediatric brain tumors for that matter. So, and building on a previous point, I think, we have been doing a lot of this genetic analysis up front. So patients that have not been treated, so they haven't been exposed to radiotherapy, they haven't been exposed to chemotherapy or a targeted drug for that matter. What we don't have is the genetics subsequent to that treatment. We don't know how the tumor changes in response to the current standard of care and how the tumor evolves, et cetera. And so that's where we really need to dig our heels in and sort of better investigate and better understand so that we can identify patient-specific therapies to both current drugs as well as those that are on the horizon.
Hi, my name's Patrick. I'm just turned 40, and I was diagnosed 17 months ago with a glioblastoma. I've got apparently a better version that's mutated. And I've gone through the traditional therapy. Firstly, I wanted to say, as the lady said in the back, fantastic that you're here, and Susan especially. It's really, it's a mini celebration of understanding patients. And I think patients first cannot be underestimated how important it is. I think we've all been in meetings where the people just, you ask questions outside treatment and think, I don't know, you can do what you want. And I think it's giving patients the inspiration to know they have more control, as Colin said, control and positivity, something that really makes a massive difference. The challenge is that I think getting everyone involved to talk about that and focus on the patient, to go and give them and tell them they got more control than they think, to go, you can do what you want, you have more power than you think, not just every month when you go and see your oncologist. So I found that I had my local GP was like, can you come in and talk? I was like, what? Can you come and talk about what you're going through? I was like, surely you know this. And it's amazing to see the gap between the lack of knowledge between what patients go through, what they think, and what the families think, and what everyone else thinks. It's an assumption that patients make, that I'm just going to sit and be told to do. No, it's an open question, and they've got to make that decision, and it's really scary. But sometimes you get it right. You think you don't know, but I think it's maybe a thing to do to help doctors and the medical side understand that better, and not just have a rota of meetings, right? Half an hour with you, bang, out. Half an hour with you, bang, out. And I found that I'm doing a bit of my work, and a bit of a positive element is helping people run well-being and mental health. It's all linked, isn't it? It's not just physical, it's mental and emotional. And hopefully we'll see what happens. So my kind of question is, especially from a patient standpoint, is where do you go to find the right questions to ask? If you have that control, you have 30 minutes to ask about clinical trials or those kind of aspects. What are your thoughts about that?
Thanks, Richard. I mean, I think the first point of reference is always the care team. I think we often get inquiries from individuals, particularly as researchers. We'll often receive inquiries about, what do you think about the biology of my tumour? And the difficulty is it creates a real sort of scattergun effect of what could possibly be done for that patient. And the advice we always give is that the primary care team is the team that you should be consulting to get the best possible information. At the end of the day, it's their role to distill down all that is going on, right around the world, from the most revolutionary research discoveries that were made last week, right through to the tried and tested therapies that have been around for 20 years. And it's their job to integrate all of that into an integrated diagnosis and provide the best possible therapy. I mean, that doesn't necessarily square with the pace of research, which is always, perhaps I think, what can be a real confusing factor to many patients. And I think it leads many patients very naturally to want to know everything they possibly can about their disease. And if you go to the literature, if you read the websites, if you read the research websites, you can find out all manner of information, much of which will only perhaps have been reported recently by a research group or is only based on one study, and there just isn't the weight of evidence to apply something clinically. So the care team is the very short answer to that bigger problem. It doesn't stop the natural curiosity of the individual in getting out there and trying to understand as much as possible. But I think that's where it perhaps links to what Susan was talking about. It's to use the care team and have a dialogue not just with the doctors but the whole of that care team to make the most informed decision and have the most informed view about the disease. And that, I think, allows you to put perhaps what this myriad of information is into a sensible set of understandable elements which ultimately boil down to the treatment you would receive.
Do you want to comment, Sue?
I think at the initial diagnosis, it's so overwhelming for the patients and the families, and information overload doesn't help at that point in time. And so what we try to do is actually really focus the information we're giving that's appropriate to each time. I kind of talked about that a little bit. But there are ways to think about your visit. And so what we've implemented, just last week actually, is when the patients come in a waiting area before they get checked in and everything, they're given a list of questions about how they're doing and if they have any symptoms. That's sort of standard sort of intake. But then we have a specific question saying, what are the 3 questions you want addressed at this visit? And we have the patient and the family fill it out, and then they give that to the physician so that, we're primed. Because a lot of times you're stressed yourself. You're coming to hear about the results of a scan, things that you thought you were interested in learning about, you may not be anymore. And so we're trying to sort of be a lot more proactive with that visit so that we get as much out of that visit for the patient and the family as much as possible. So that's just another way to think about it. So be prepared when you go as well with your team.
Great, thank you, Susan. And I think another thing that sets Susan apart which was very striking, is she kept saying, a patient came to me and said, "You're crap at this," and she listened, right, and changed stuff. And actually, many physicians will be affronted by that and actually take a sort of arrogant response, actually. And so, so physicians like Susan are rare, but that's fantastic. What we're doing in terms of the Test-a-Child brain cancer mission is to make sure that happens in centres. And by having that badge, if you like, that shield mark, Test-a-Child, is to make sure that we're starting to get centres where this is an absolute expectation. And if you want to keep that badge, you better be doing this kind of stuff. And that's what the Test-a-Child brain cancer mission is about. So thank you, Patrick, for your question.
I mean, if I can just say as well, certainly from a paediatric perspective, I think clinicians are far more used to hearing this sort of information being brought to the clinic now. So it's not like it's a new thing for them, that they will frequently have to have these consultations where a patient may even have chosen to have their own genome sequenced as part of their workup, and And so the clinicians are becoming better and better practiced. I'm not quite sure how that plays out into the adult community so much.
So, from the microphone, right, sorry, back at work. I don't know who was next. I don't want to sort of. Okay.
Thank you. Hi, I'm Kate from Cardiff. My twin sister was diagnosed with, fortunately, a low-grade astrocytoma just over two years ago. At the time that we found out it was low grade, we felt lucky that, to all intents and purposes, we'd found it early. We could get to it before it became aggressive. So it was a massive shock to learn that it will become aggressive. So the bus will hit. It's just a question of when, and we're powerless to really stop that bus. My question is, whilst I can totally appreciate that the focus is on the higher grade tumours, in the effort of prevention rather than cure and chronic disease, is there much going on out there for low grade tumours to keep them low grade, to prevent them progressing to high grade? And just wondering if there's anything that I could be looking into clinical trial wise for a low grade patient.
Thank you, Kate. Ken,
Okay.
do you want to answer that? Because Ken's an expert on gliomas, has been for 400 years now.
Yeah, I think not as long as Richard, though. But I think think there is a lot of work being done in low-grade gliomas. In fact, a lot of the genetic aberrations that are seen in low-grade gliomas are very similar to those in high-grade gliomas, and that's one reason they can progress. So I don't think you should feel that the focus is only on high-grade gliomas. There's a great deal of work. There was a very large clinical trial recently done on low-grade gliomas. I don't know if Suzanne, you want to comment on that clinical trial, 9802, yeah. So there is a lot of work being done to understand the progression of low-grade gliomas into high-grade gliomas.
So again, this is driven by a patient. Sort of amazing how that keeps reinforcing. But this is a patient who has a low-grade glioma, and we actually have, Ken is on our advisory board as well. It's called low glio, so not very, it's very transparent what it's about. So it's about low-grade glioma, and there's about 4 or 5 projects, all specifically for understanding biology and also cognitive function and treatments for patients with low-grade glioma. So there is traction now, and there's a lot of interest. So you should be, realize that is happening. We're now able to target specific mutations in low-grade glioma, specifically the IDH or isocitrate dehydrogenase gene with inhibitors, and that's ongoing. The study that Ken alluded to was actually done a long time ago in '98. But got published just a couple of years ago because of the long survival time you need to really understand the effects of these treatments on patients when you're trying to understand effects on outcome. But one of the 2 studies we have at UCSF actually is on low-grade glioma patients. These are patients who have a tumor that's going to have surgery done, and we give a vaccination, and the vaccinations, they're different kinds, but they are proteins that are more commonly expressed on the higher grade tumors. So the idea there is that you're vaccinating the patient against cells that might transform to higher grade. So exactly what you just said about making this a chronic disease, because if we can keep the disease where it is, the patient's going to remain well. It's only when it starts to grow that you start to get more symptoms. And so we do have 2 trials where we're looking at specifically the vaccinations, and we're doing a lot of immune modulatory aspects. So to address the question about what works and what doesn't work, we're trying to understand the immune system and the reaction of the patients who get vaccinated and patients who don't get vaccinated before surgery, to try to look at the tissue characteristics and whether there's a lot of inflammatory cells that come into the tumor because of the vaccination. And then we're doing blood biomarkers as well. So yes, there is a lot of effort now, and a lot of this, because of the work, a lot of what the Ken did actually for low-grade glioma. So.
Great. Thank you, Susan. I think we're going to, because we're running out of time, to get more questions in, if it's okay, because I want everyone to have the chance to ask questions. So there's one on the app, right?
Yeah.
Yes.
It's a tough one. So we hear about all of this research, we hear about all these clinical trials, yet brain tumours are still the biggest killer of children and people under 40. There's still a huge unmet need. So what's holding us back? What's the biggest challenge that you face, and how do you see us overcoming that?
Yeah, I think it's because we've done everything wrong so far. And that's our approach in the CRUK Children's Brain Tumour Centre of Excellence. It's not an unreasonable hypothesis is that we've not moved the needle in 40, 50 years. Everything we've done is wrong. And so what we're doing is, in that centre, is we're understanding how the child's brain is knitted together and how that goes wrong to make a brain tumour, if you like, from soup to nuts. What is it that makes that tumour happen in the first place? And as I mentioned, sort of alluded to earlier on, is that one of the challenges we face in children is that our treatment, radiotherapy and chemotherapy, has essentially been extrapolated from breast cancer and lung cancer. It might shock you, or whoever asked the question, which is a great question. We actually use those treatments in children because they worked in ovarian cancer and in lung cancer, and that's absolute nonsense, right? And sometimes they work, but they're incredibly damaging. So what we're doing now is taking a completely different approach, and what's extremely exciting is that team, which includes Canadians, North Americans, as well as individuals in the UK, is to actually understand how the nervous system is knitted together, how it goes wrong, including experts on Alzheimer's disease, other neurodegenerative disease, biochemistry, and then completely throwing the rule book out in terms of conventional chemotherapy and radiotherapy and looking at treatments which target that abnormal neuroscience. And that's really exciting to take a completely new approach. So that's the route that we're taking.
I think the other thing as well is to note that one of the strategies within the Brain Matrix program is to try and learn from failure. Because as I said in the talk, we haven't learned from failure, and I think that's why we haven't made as much progress. It's about how we redesign not just how we do trials, but the whole process of how we care for patients.
My name is Sandeep. My mother was diagnosed with jugular foramen, thankfully low-grade meningioma. It's large in size, so we were suggested not to undergo a operation. But she underwent a stereotactic radiotherapy, and for the last 3 years she's been suffering with the side effects, which you would expect from the conventional radiotherapy. She's unable to sleep. She gets headaches very often. Has there been any development? And she has taken a lot of drugs ever since, trying to kind of control her side effects. Has there been any development with the side effects from the conventional radiotherapies, or is that something that is what it is?
Susan.
So it sounds like she's probably been on Decadron or steroids medication, and that is probably why she can't sleep, because one of the side effects is insomnia. So steroids is sort of what is classically used for patients. There's actually some data as well as using bevacizumab or Avastin. So you probably all have heard about Avastin. It targets the blood vessels within the tumor and the areas around the tumor. And there's actually been studies that show that you can reverse the sort of inflammatory changes from radiation by using Avastin. You don't have to use as much, you don't have to use it as frequently. So that would be possible. But again, as Richard pointed out, every patient is individual, so there may be contraindications for why you don't want to give that drug. So it has to be something you discuss with your primary care team in terms of that option. And then I guess the other would be potentially surgery. So sometimes if there is a big mass that can be debulked or removed to relieve some of that pressure that's happening and take the inflammation out. You kind of have to break the cycle sometimes, but maybe Colin, you could mention that or talk about it.
So surgery certainly has a role. I think it's about tailoring the right treatment to the right patient, and I think what you're talking about is more about the side effects from SRS. I don't think surgery has a real role in terms of dealing with the side effects, but there are certain patients who can benefit from surgery and certain patients, for whatever reason, who would benefit from SRS. I think increasingly, and maybe Ken can comment about meningiomas, we're learning about the pathology. So we're learning there are more types of meningioma than we thought, and that is helping us guide and prognosticate and think about how things are going to develop in the future. To do that, we need tissue. So I think surgery does have a role rather than just going straight to SRS. Because I think certainly as the methylation-based classification comes into mainstream, I think that will have an effect. Ken? Yeah, there you go. Yeah.
Tissue. Yeah.
Great, thank you. So we're on our last question, which is over here. But what I would say, if you do have a question, please find anyone with a red lanyard, give your question to them, they will get them to me, and we will answer them for you by email. We'll probably pass them back through the office. So we will answer your questions. I'm sorry we're running out of time tonight, but we will do that for you. So if you've got a question, anyone with a red lanyard, and we will get those questions answered.
Hi. I wanted to say how fantastic it is that Dr. Chang has come here, and because our son is being treated at UCSF by, it's just, we're British, he works in San Francisco.
Oh, okay.
So we can vouch for for the fantastic approach that you adopt there. And he's confident, he's calm, and I'm delighted to hear we're going to get a binder when we go out there shortly, because that was one of my questions. But he's keeping calm. How do we keep calm? I just wanted to really back up what you're doing.
Oh, well, thank you so much. So I think it's knowing that you're doing the best and your team, and by having the kind of support that we're hoping to offer to sort of make you feel resilient. So that one of the things that we work on very consciously is this form of resilience for our patients, because it's a long journey, but also for the caregivers. And so we actually have training sessions about how to deal with this, and I think that's something we need to do better at too.
Great. Thank you for your question. So I'd like to thank our panel, SAB members. Thank you.